approach to tachy is going to be this. Tachyarrhythmias. Of course, I will start with my rate as well to know that there's a tachyarrhythmia. So first step, rate, which means the rate is typically going to be greater than 100. So when I see this, I have my differentials in my mind. But then the second thing we usually do here is not to reading. It's not reading. The second thing we do is what? Check your KRS complex. Because tachyarrhythmias, let me talk about origin. So you can understand why doing that is going to be important. Tachyarrhythmias, they have two broad origins. They can originate from the ventricle, originate within the ventricle, or they can originate above the ventricle. So if a patient has a tachyarrhythmia, and let me even be more specific. So this is our left atrium, right atrium. This is our, of course, tricuspid valve ring or annulus. Mitral valve is here. And then you have your opening, right, of the left, of the pulmonary veins into the left atrium. There are some tachyarrhythmias that originate where around the opening of the left, around the opening of the pulmonary veins. So if there's a like dilation of the left atrium and stretching of the ostia, right, or opening of the pulmonary veins, this can lead to multiple abnormal focus, right, firing here. And this is the origin of what? Of AFib. There are sometimes there'll be a pathology in the right atrium, maybe enlargement, dilation, whatever, that will lead to stretching of the tissues around the annulus, the ring, the opening of the tricuspid valve, right? And this is usually the origin of a flutter. Then sometimes there's going to be pathology in the muscles themselves, like in the right atrial muscle, it is somewhere random, multiple locations that are firing in sequence, not at the same time. So for AFib flutter, it's usually like simultaneous firing. Sometimes they have this multiple abnormal focus scattered around everywhere. There might be 2, 3, 4, etc. at different locations, and they are firing in sequence, not simultaneously, but in sequence. And that may be the origin of what we call multifocal atrial tachycardia, from the name multifocal points of firing, right, in sequence. And then this is my AB node here. Sometimes the focus can originate in the AB node itself. We call that the re-entry circuit. Re-entry circuit, and this is going to be AVNRT, atrioventricular nodal reentrant tachycardia. Yeah, so AV. What are all these called? All these classes called? They are all called what? SVTs. Does this make sense? All originating above, right? The ventricle somewhere. Where else can arrhythmias originate from? They can originate within the structures at the level of the ventricles. Bundle of E's, Purkinje fibers, from the ventricular muscle itself, and all this will be what? VTs. So possibly? Excellent. Okay. Now, so why is it important for me to check my KRS complex, doc? KRS complex represents what? Represents it's going to give me an idea of the status of the ventricle. Tells me if the ventricle is normal or abnormal. If a patient has an SVT, pathology above the ventricle, what happens to ventricular depression is going to be normal because there's nothing wrong with the ventricle. So my KRS complex will be narrow. It's going to be normal and narrow if I'm dealing with an SVT. But if the pathology is within the ventricle itself, my KRS complex will be slower and wide, which just means a VT. Does this make sense? Mm-hmm. Right. And once you see wide KRS complex, I just pick VT, you're done. I don't even need to look at anything else. But now it's not for SVT, we don't need to know how to tell them apart because we have about 4 SVTs there. We need to figure out how to tell them apart. So what do we do now? You now go to step 3. And if it's an SVT, You suspect because of narrow KRS complex. You go to step 3, and then you check what? You check the rhythm and P wave. That is things you're going to do for step 3. Check the rhythm and then check the P wave. Look for P waves. If my rhythm is regular plus no P wave. So narrow KRS complex, rhythm is regular, but you cannot find P wave. Either the P wave is buried, because the P wave is buried within the KRS complex, or sometimes you're going to see it after the KRS complex, like an inverted wave. This is going to be AV NRT, which makes sense. If an arrhythmia comes from the AV node, what will it do? It's going to depolarize the ventricle and the atrium at the same time, right? And which one is bigger? Ventricle, right? So you're going to see the KRS complex, but the P will be buried inside. You won't see it, right, separated, because they are occurring at the same time. Yeah, so that would be AV NRT. If it's regular, typically regular, and you see flutter, or what we call sawtooth rather, sawtooth P wave. So you see the P wave, but it looks like the tooth of a saw. That would be a flutter. So sawtooth P waves will look like this. Yeah, they try like the tooth of a saw. So a flutter. If it's irregular, rhythm is irregular, and no P wave, you cannot find the P wave. Erratic baseline, irregular, there's no single identifiable period, that would be what? A beep. And if the rhythm is irregular, plus you see at least, right, 3 different types of P waves. So the P waves, 3 different types of P waves. Look different in shape, size, morphology, things like that. This is going to be multifocal intracardiac, right? So you have multiple sorts of depression, right, in sequence. Yeah. So quick recap. Approach to tachyarrhythmia, of course, starting with your rate. The rate is more than 100 of I'm doing with tachyarrhythmia. This will be my differentials, SVTs and VTs. So I've forgotten everything about the other guys. My VTAC and my art blocks and stuff, which will be bradyarrhythmias. So then check your KRS complex next to kind of determine the anatomic location of the arrhythmia. If the KRS complex is narrow, you know the ventricle is LD, so it has to be an SVT. The KRS complex is wide and the ventricle is slow to the rise, then the problem will be a VT. If it's VT, why you see VT, pick it down. If I suspect an SVT because of narrow KRS complex, next I have to check the rhythm and find P wave. If it's regular and they tell me, or I see no P wave, it's going to be AV and NRT. The origin is from the AV. If it's regular, sawtooth P wave, a flutter. If it's irregular, there's no P wave, a V, which is the most common, which you have to know for sure. And if it's irregular, and I see at least 3 different P waves, there will be multifocal atrial tachycardia, which may be related to COPD, right, and stuff. So that is going to be your tachyarrhythmias. Excellent. Good.
Yeah. Yep.
Based on this diagram we have here, do you understand why carotid sinus massage may be beneficial in patients with SVT? Yeah? Do you see why carotid sinus massage may be beneficial in patients with SVT? Yes or no?
No.
What does carotid sinus massage do?
I know it decreases like heart rate.
How?
I know they rub the carotid,
Mm-hmm.
and then when you rub it, it increases the pressure.
Doesn't increase the pressure. The sinus becomes activated, thinking the pressure is high. Correct? Okay, go ahead. And
then it's gonna reduce the heart rate.
how will it decrease the heart rate?
Cause Vasodilation.
The heart rate will reduce because I'm dilating the vessels. Blood decrease the heart rate up.
Oh, vasoconstriction.
Why are you talking about the vessel when you tell me about the heart? Are they the same structures?
No.
How would I decrease the heart
No.
rate?
Decrease the firing at the SA node.
Okay, what else will happen? Is it only the SA node that will be inhibited?
And then the AV node.
So where is the AB node located anatomically?
Below the SA node.
So where is it located? Between the atria and the ventricle, basically, right? Correct? On this diagram. Do you see how blocking the AB node may be beneficial in somebody with SVT or not?
Yes.
If a patient has an SVT, where would the arrhythmia go through to get to the ventricle?
The AV node.
Right. So why is the heart rate, why is the pulse fast? Because the SVT gets to the ventricle is beating fast. Yes or no?
Yes.
If the ventricle is beating too fast, what happens to my cardiac output? Eventually,
Increases.
it will
Increase.
initially increase, but what happens if it's beating like 300 beats per minute, 400 beats, 500? What will happen?
It'll slow down.
What happens to my cardiac output? Eventually, if the heart rate is ventricle is beating at 500 beats per minute, what happens to my cardiac output eventually?
It'll decrease.
Why?
Because it won't be able to maintain that over a long period.
Over a long period of the heart can fail. It's working too fast. That's one. Two, what else? If the heart is beating at 500, how much time does it have to relax and feel with blood?
Less time.
So what blood will it pump out? Less. If it's not feeling, it's not pumping out anything. Even if it's beating at 500, there's no time to feel. So what happens to the patient cardiac output eventually is going to go down. They can go into shock, hypotension and stuff. Yes or no?
Yes.
So if I see that kind of person, I immediately started massaging their carotid sinus, or I immerse their face in cold water, or I ask the person to do a Valsalva maneuver. What will all those things do? They're going to increase vagal tone, parasympathetic, right? And what happens to my AV node? You block it. So all those arrhythmias, would they be able to pass to the ventricle?
No.
No, and what happens to your ventricular rate? You're going to be able to bring it back down, right? Like within normal range and try to maintain cardiac output. But are you terminating the arrhythmia? No, you're not terminating the arrhythmia. You're just making sure that the ventricle is still beating at a normal rate, regardless of the arrhythmia being there. Does that make sense?
Yeah.
Right. Remember our class 2 and class 4 antiarrhythmics, correct? Class 2 being beta blockers, class 4 were calcium channel blockers, verapamil, diazepam. What effect do they have on the heart?
They will decrease the heart rate.
They would increase heart rate by doing what? By doing what?
The SA node and AV node.
They block SA node and AV node, yes? Okay, would those drugs be beneficial in somebody with SVT?
Yes.
Yes. If somebody has SVT, their ventricular rate is 500, I give them beta blocker, it's going to bring down the ventricular rate by blocking the AV node. But is the drug terminating the arrhythmia?
No.
No. It's just controlling the ventricular rate. We call that rate control. Does that make sense? Make sense?
Yes.
But then my class 1 and class 3 antiarrhythmics, which are what? Which are the ones that work on the myocardial action potential, right? Those ones are the ones I can use to do what? To terminate the arrhythmia itself, because they work on the muscles. Where are the arrhythmias coming from? They're coming from the muscles, right? Of the atrium or the ventricle and stuff. So if I actually want to terminate the arrhythmia itself, I'm using class 1 and 3. my sodium channel blockers, the phase 0 blockers, and my potassium channel blockers, right? Phase 3 blockers. Yeah, class 3 antiarrhythmics. Those will not target the muscles, the focus, this abnormal focus or foci where the arrhythmia is coming from and basically shut it down completely. But if I don't want to do that, I just want to control the ventricular rate. If it's an SVT, I can block what? The AV node with a class 2, 4, or I do cold water immersion, carotid sinus massage. I give adenosine, all those ones, they're going to block the AV node and help you control the ventricular rate, even though the arrhythmia is still there above the ventricle. Make sense?
So class 2 and 4 is to control the rate and the SA node, AV node, and then class 1 and 3 is to move to fix the myocytes itself and take care of the arrhythmia.
Exactly.
But okay, yeah. But 2 and 4 is to maintain with the arrhythmia.
Right. So in VTs, if somebody has VTs, can I use in ventricular tachyarrhythmias, which are arrhythmias coming from the level of the ventricle itself? Will class 2 and 4 carotid sinus massage, vagal tonitis, will those be effective in those people?
As VT?
VTs, will those be effective in VTs?
No.
Why not?
Because and VTs is coming from the ventricle itself.
So the VTs is coming from below the AV node, right? So blocking the AV node will have no effect on the VT. Make sense? Yes?
Yes.
But will class 1 and 3 be effective though against VTs?
Yes.
Yes, because they are targeting the muscles directly in the ventricle itself. Is this clear?
Yes.
Yes. Yeah, that's how we choose antiarrhythmics. We don't just, we're not gambling. We choose them based on where they work or based on it, which determines, we choose them based on the type of arrhythmia and based on where the antiarrhythmic works. If the arrhythmia comes from somewhere above the ventricle, of course, I can use antiarrhythmics that will block either the atria or block the AV node. But if it's coming from below the AV node in the ventricle, then anything that blocks the AV node will be useless. Only the ones that block the muscles themselves will work in that case. Make sense?
Yeah. What class is the 1 and 3?
Sodium channel blockers and potassium channel blockers. So look at this ECG and tell me, read it for me, the first one. Oh, wait, before I go to this one, sorry, there's one more point here that I want to highlight here in this picture. So another thing I want you to know here is, and let me use a green here. So let's say somebody was born, right, with a conduction. You see where I'm shading green.
Mm-hmm.
So somebody was born with an abnormal tissue, a conducting tissue, right, that directly connects the atria to the ventricle. And that is bypassing what the AV node. Typically, only through the AV node is like toll gate, right? AV node is like toll gate. You can only go through. Does that make sense? The toll gate on the highway, right? In the heart, AV node. But sometimes there could be a way, right, to bypass that, like a back road, wherever, a dirt road. So that green pathway is like that in some people's heart. It's a pathway that can bypass the AV node and allow action potential to go through to the ventricle. Now, if a patient has, right, somebody has an SVT, supraventricular tachyarrhythmia, like AFib, MAT, A-flutter. Where will the action potential go through? It's going to be going through this green pathway, right? Not the AV node. Remember, the AV node is slower.
Yeah.
It's going to be going through the green pathway. So for every maybe 3, 4 waves that go through the green, only one will go through the AV node. Tell me what happens to that patient's ventricular rate compared to a healthy person that doesn't have that green patch. So a healthy person has an SVT, but there's no green patch. So all the action potential goes to the AV node. Now compare that to somebody that has an SVT, but they have that green patch that can bypass the AV node. Who has a faster ventricular rate?
The one that has the green.
Exactly. So this is gonna be bad. These people, if they don't have an SVT, right, you won't know that they have anything. You won't know that anything is wrong with them. They're healthy otherwise. So if they have an SVT that will cause maybe a heart rate of 200, ventricular rate of 200 in a healthy person, will cause a ventricular rate of 4, 5, 600 in that person, and they can die suddenly from that. And this is what we call Wolff-Parkinson-White syndrome. If somebody has this, that's green patch bypassing the AV node, right? We call it the in case they ask in the exam.
Delta.
No, I'm gonna tell you what you're gonna see on ECG for this, but there's a name for that accessory pathway. I've forgotten the name, but there's a name for the accessory pathway itself, the green patch, there's a name for it, but that green patch basically bypasses, right, the AV node and stuff. Now, another question I want to ask you in these people is this. If somebody in this person, somebody with this green patch, is it advisable, right? Is it advisable to use AV node blockers in this person?
No.
No, because if you block the AV node further, the action potential is going through the patch even faster. Does that make sense? And the risk of death is higher. So what class of antiarrhythmics will be best for this person?
1 and 3.
1 and 3. Because 1 and 3 will block the patch, but will not affect the AV node. So the arrhythmia can go through the AV node, but not the patch. And that minimizes their risk of what? Sudden death. Does this make sense?
Yep.
Okay, right. Now we're talking. Now let's look at, let me show you the ECG for Wolff-Parkinson-White. Like you mentioned the delta wave, let me show you that now. And you're right. So we can basically predict what we expect to see. So these are people for this ECG here. Actually, the one at the bottom. So this is P wave. Do we have a PR segment here? We don't. You can see that immediately after the P wave, what do you see? You see the KRS complex, right?
Yeah.
Going up. So which tells me that what? The action potential is not going to the AV node. So that's why I don't have that PR segment. It's bypassing the AV node and going to another accessory pathway. So these people usually have absent or no. So you're going to see decrease or no PR segment in these people. Then, like you mentioned, there'll be a slow upstroke of the R wave, KRS complex, and that creates that delta wave, basically, that we have here, delta wave, right? Which is the delta wave. And then you're going to see wide KRS complex. Like the KRS complex here, they are wider than like 3 small boxes up to like 1 big, right? Because of course, if I bypass the normal conduction pathway, right, the ventricle will depress slower than usual. So the wide KRS complex. So if you see this combination of these three, we call this pre-excitation combination. You see these three combinations. This is somebody with an accessory pathway in the heart, and it is diagnosed for Wolff-Parkinson-White syndrome, and they're at high risk for sudden death if they have an SVT. Right. Excellent.
Mm-hmm.
Okay. Now let's go to the first one.